welcome to Public Health in Real Life. I'm Ashwin Kadambi.
Hi all, I am Marisu.
Okay, we are in for an important discussion about equitable access to mental health services for refugees globally. Now, the UNHCR, which is the UN body which is the UN body for providing aid and protecting refugees, estimates that refugees make up more than 1% of the world's population. And they face significant barriers when it comes to mental health services. While considerable progress has been made in the past decade with increasing access to mental health and psychosocial support in development and humanitarian programs, much needs to be done. And to illuminate us further, we have Srishti Sardana. So let us add Srishti to the stream here. Hi, Srishti. So Srishti is the expert to talk to. Srishti is the medical psychology fellow at the Duke University School of Medicine. She recently completed her doctoral studies at the Global Mental Health Lab at Teachers College, Columbia University. Now, the Global Mental Health Lab is the world authority which studies the efficacy and effectiveness of a variety of mental health interventions to treat vulnerable populations in low and middle income countries. She's a former corrections officer in India working with the Delhi Juvenile Justice Aid with the Delhi Police and a co-founder of a mental health nonprofit in India. She's a scientist practitioner with clinical interests in study of deep depression, HIV/AIDS, and mental illness comorbidities. Her research expertise is in social capital networks and determinants of mental health among underserved populations, including sex workers, juvenile sex offenders, refugees, and displaced populations globally. Srishti, welcome to the show.
It's my honor, and I'm very humbled to be here.
Well, thank you. So, Srishti, can you give us a sense of the global morbidity, mental health global morbidity among refugees and internally displaced people, and the unique mental health challenges they face?
So, Ashwin, there is no straight answer to that question, right? We have to take a step back and say, all right, so there is 79.5 million forcibly displaced people worldwide, right? This is at the end of 2019, we knew that 26 million of those were refugees and 45.7 million of those were internally displaced. Mm-hmm. So they weren't sent away from their home countries, but they were forcibly displaced within their living contexts. Right. So these are big numbers, right? And so as you were saying, Ashwin, that constitutes about 1% of the world's population. But here is the problem. 80% of those 1% in the world's population are in countries that experience acute food insecurity and malnutrition. And 85% of them are hosted in developing countries.
Yeah.
What a shame.
Yeah.
Because these are 85% of the 79.5 and kind of growing number of, forcibly displaced people worldwide are living in countries that are already strained for resources.
Yeah.
Whether it is health, whether it's education, whether it is living, whether it is food. Right. So when you think of mental health morbidity, we have to understand that when people lose everything they have, their home, their land, their legal and civic rights, their families, the people they love, their places of worship and gatherings, their first instinct is not so much towards mental health well-being. The first instinct really is about safety and protection. So some main questions to think about in terms of mental health morbidity of this part of the world's population, those questions are often not, how am I doing today?
Yeah.
Right? Those questions are more likely, where are my children?
Yeah.
Did all my family make it?
Yeah.
What am I going to eat? Where am I sleeping tonight? Am I going to be alive tomorrow? So these are just some kind of perspectives to keep in mind when we think about mental health morbidity among people that are constantly being moved, right? A person is displaced every 8 seconds. What is that about? We also know that there is, from some systematic reviews and some scoping reviews of the last 5 to 8 years by many world champions in this area, including the UNHCR. We know that there is prevalence of what we would call as the post-traumatic stress disorder.
Yeah.
Right? That right after a very, very difficult series of experiences and tragedies and losses, people do have a very acute, a very heightened response to those cascades of losses. We call it trauma because, although trauma is on a continuum, we think of it as an immediate flee or freeze or fight response.
Yeah.
Right? That's an animal instinct in us human beings. So yes, there is some literature to say, well, there is mental health morbidities from the point of view of this post-traumatic stress response. However, I do want to point out, when we think about it in terms of post-traumatic stress, what events the refugees and displaced folks are responding to are not prototypical. These are not routine tragedies. We're talking about exile. We're talking about genocide, right? So there is that part of it. There is also some research, and a lot of this perspective has actually come from, my advisor, Dr. Lana Verdelli, and her colleagues in global mental health space, that talk about how right after the displacement experience, you would expect that people have this, fight, flee, or freeze response, the trauma response. However, very quickly afterwards, that begins to settle down, and what one actually sees is this type of sadness, this type of recognition that, oh my God, I've just lost everything I had. Who am I? Right? Including a sense of self. That's where, the depression and the distress sets in.
Yeah.
So there is some prevalence data around, all right, so there is the post-traumatic stress response right at the outset, following this emergency, this humanitarian emergency.
Right.
And then there is the settling in of the loss and the tragedy. And what one sees then is the sense of kind of depression and distress, because that's when people begin to recognize my rights and my fundamental sense of honor and self have been stolen away, right? So those are some perspectives around how to think about mental health morbidities when we're thinking about this population globally.
Yeah, and definitely there's a huge sense of loss with people losing their homes, and they don't have a clear future to their lives. And so could you tell us a little bit about or the mental health, the morbidity is, what percentage of people might be having illness that predates this traumatic event?
Ashwin, you ask me questions that really global health experts are, struggling to get clear answers to. But kind of piggybacking off of, some of the more recent work that, global health experts, including Lana Verdelli and Vikram Patel and others have done, they connote that there is, there are definitely the emergency related responses. The emergency occurred, people got displaced, and they developed, mental health problems and concerns and, needs in terms of financial aid, in terms of food and nutrition needs, in terms of sanitation and hygiene needs, in terms of health services, right? Reproductive and health services.
Right.
We have to think about it as, all right, the emergency occurred and these needs have come as a result of the emergency, which is where a lot of the UN agencies come in, right? Which is, by the way, where us social scientists meet these populations. So if you think about it in a critical way, we are capturing samples of people once they have been displaced, right?
Yeah.
Whatever data we are collecting around prevalence of mental health problems once they have been displaced, very unique sample of people that have just experienced displacement.
Sure.
So obviously, there is a temptation to say it's linked to the emergency.
Yeah.
Right? There is a temptation to quickly associate the two. However, we take a step back, and in much of the work that we do at the lab, we take a step back and say, well, causality is not the same as correlation. Of course, there's a correlation. Something terrible just happened.
Yeah.
So, of course, I'm going to have a very difficult distress response. Right? It's only human for us to experience
Absolutely.
it. However, whatever was happening beforehand, whether it was the anxiety of being displaced,
Yeah.
whether it was the fear that any given day my future will be robbed away from me,
Yes.
or the fact that there was this kind of, imagine that we are living, if one was living in this constant uncertainty about what next in my life, there's only so much we can tolerate that.
Yes.
Because all of us, refugee or not,
Yes.
want that sense of certainty of our next day, right? Of our next hour. We plan things that way. It keeps our executive functioning going, right? We become adaptive, functioning human beings as a result of that type of executive control in our lives.
Yeah.
And now then to be suddenly robbed of that in all realms, like, will I have this job tomorrow?
Yeah.
Am I going to wake up alive?
Sure.
Will my family be around me? So there is that uncertainty. Obviously, that compounds, even for whoever are the healthy adults doing well in life, that level of uncertainty has deleterious effects.
Yeah.
And a good analogy to think of it this way would be, and Ashwin, I'm kind of looking forward to some of the research that experts in the field and are going to produce from the COVID crisis around the world.
Yeah.
Because we have been in this prolonged uncertainty for such a long time.
Yeah.
I wonder what that experience would be.
Yeah.
So in a nutshell, what I'm really getting to is that I would look at it as, there are correlates of this humanitarian emergency experience with the mental health needs.
Yeah.
However, it's not that one caused the other.
Sure.
Right. Therefore, like a number of people, and there are trauma researchers and there are resilience researchers who've pointed out that a number of people actually recover and kind of go back to their baseline pretty quickly following cascades of disasters. So that's just something to keep in mind too. And I'll kind of wrap this up with this interesting perspective around how all of this thinking actually ties into how interventions are thought about.
Yeah.
And we can go there if you
Sure.
so wanted.
Okay, Srishti, thanks so much for this great insight. So the next question I want to know, when designing interventions, how should programs choose which mode of therapy to provide to give to a given population so that it is tailored?
Yeah. Marius, I was, recently looking at what is the perspective that the UN High Commissioner for Refugees, Dr. Peter Ventervogel, who's the Senior Mental Health and Psychosocial Support Officer at the UNHCR. He's provided, he was giving a presentation and he collated some very important perspectives around, what mode of intervention, And I kind of resist calling it therapy. I say, okay, it's a mental health support intervention. Because, therapy is, I mean, you and I understand that.
Yeah.
Frankly, that's not the language I adopt when I speak to my parents in India, right? So that's the tailoring aspect when it begins. That's where it begins. It begins at home for some of us that have come from developing countries or low and middle income countries where the concept of therapy really doesn't exist. But the concept of, or it's a new concept. But what has existed in cultures around the world are systems of care. We've always had systems of care. In the small part of India where I was born, and then in Delhi where I was raised, between the rural and urban worlds, it wasn't that there were therapists around, but there were a fair number of people, individuals and communities as collectives that did provide quintessential care that was directly important for and needed for the mental health well-being of a person. So taking a step back, I would say like designing interventions have to fundamentally involve people on the ground. So the first question cannot usually be, and again, this is my perspective, right, in just being trained in global mental health. And I have to say, I'm hearing my advisor in my brain, and I know that she would say, well, when you go to a field, you don't say, I have interpersonal psychotherapy, and, we do cognitive behavior therapy, and here it is, and we're going to do it. That's not how we start. We go and we say, well, there are certain things that you have been up against. There are certain challenges that look like mental health problems in your context that your own systems of care have not been able to manage in a consistent and effective way.
Yeah.
And it seems like you're really stuck. How can we help?
Right.
Or how can we help you?
Yeah.
Can you guide us? That's tailoring fundamentals in my mind.
Sure.
Before we get into the complications of, we have to obviously translate the materials. We all also have to think about cultural and contextual adaptation, but keeping all that jargon away. What is essential is that you went somewhere, right? You come from the US, you went to India,
you
come from the United States, you went to Bangladesh. You're not taking your manuals of CBT and IPT with you.
Really?
You're not doing that. You're going in and you're saying with a sense of personal humility, there are certain things that you're really being challenged by in your communities. It seems like, and a good example of that, Marius, will be that, there are countries where suicide is criminalized, right?
Yeah.
I mean, there are significant. I know it sounds like a paradox.
Yeah.
A person was already ready to take their life.
Yeah.
The person was already ready to kill themselves because they had depression, and then now you save them and you put them in the jail.
Right.
There's a paradox.
Exactly.
But in a number of countries around the world, suicidality and suicide attempt in itself is criminalized.
Right.
You're not going to go in and say, oh, when you're having thoughts of suicide, call this helpline.
Yeah.
So, tailoring is not about creating a helpline. Tailoring is kind of respecting.
Right.
What are the rituals? For hundreds of years, how have these people in this particular region managed people without a will to live?
Right.
So it's co-learning, it's co-developing, it's collaborating. And to me, that is tailoring an intervention. And then you can call it whatever. You can still call it CBT.
Yeah, actually, Srishti, that takes a lot of humility actually to not just go and dump what we know and try to treat the people as a subject matter expert in this area. Rather than that, to really listen and understand the, assess the needs of the people, and then tailor the responses. But when it comes to the implementation, we have multiple donor agencies and NGOs that rush into the humanitarian arena or development arena, each having their own vertical programs with different therapy models and different modes of care and treatment. Is this, how can we rather integrate a unified national response? And perhaps, I don't know if organizations like the OCHA, which is the Office of Coordination during Humanitarian Assistance, those kinds of bodies can have an influence into how to integrate and provide comprehensive mental health care rather than doing it in silos.
Yeah, I think that's a very important question, right? Because obviously, when you say vertical
right.
versus horizontal, right, versus integrated, right? There's already a lot of challenge in imagining what those care systems look like. First of all, the question is, do they exist in a particular region?
Right.
What is the power that they're exerting? Obviously, the people living in the community did not one day come up with this notion that, suicidality will be criminalized. No, it was a vertical system. Somebody in the government would have decided that let's have a policy around this. Let's put these people also in jail with everybody else that's committing an offense, right? So obviously the governance has a role to play. If the governance has role to play in a particular region, it means that that is representative of what they stand for.
Right.
It's as simple as that.
Right.
If a particular government has certain ethos, certain values that guide their thinking, of course that will guide how they think about developing programs. Of course, that will guide how they think about divestments and investments. Of course, that will guide who they hire and how they implement programs. Right?
Yeah.
So that's one aspect. Then the other is, the horizontal structures.
Right.
Sometimes non-profit organizations that have emerged from horizontal structures, advocates and allies and people with lived experiences of adversity, usually, come from this horizontal structure.
Yeah.
So there is obviously a disconnect. I don't see it as a gap necessarily. I do think that, non-profit agencies and community care settings do serve a very important function.
Yeah.
And I also think that the governance structure is needed to be able to systematically keep the country together, keep that region together in terms of policies, in terms of legislation, in terms of protection rights.
Yeah.
So I don't see it as a gap, but I do see it as they're not necessarily doing the same thing.
Right.
They're serving a different function.
Right.
However, OCHA, like you were saying, Ashwin, and other agencies, they, from an academic point of view, there are very clear guidelines and different levels at which, we have to think about, what are the priorities of the government sector? If the priorities of the government sector is to say, I have, X number of, or X amount of money to invest in healthcare in a given year, and only 1% of that I will put aside for mental health.
Right.
Let's honor that and work with it.
And when, sorry to interrupt, but you're talking about the host country national government, right?
Yeah.
Like, for example, if it is in the Syrian refugees, you're talking about the governments like the Jordanian government and Lebanese government.
Exactly.
Their response structures.
Exactly. And especially because, these are not ordinary decisions.
Right.
These are not everyday decisions that vertical or horizontal structures of care are taking. That already is a problem, right? Remember, we started this whole discussion with saying 85% of the people that are displaced and are refugees are living in developing countries.
Yeah.
So these are countries that already have very limited budgets set aside, whether it's their vertical or horizontal care structure.
Yeah.
However, what I have learned from the last 3 to 4 years of the work that is being done at my lab, and actually what Dr. Verdelli kind of spearheaded way was this direct collaboration with the government in lab, right? To say, well, we want to work with the Ministry of Public Health to kind of understand and honor what the policies are. And they have really championed this type of budgeting and developing mental health systems of care for both the Syrian refugees and other refugees, as much as they have on the Lebanese host. And Ashwin, I have to point out that is a rare, right? Like that's a very rare scenario.
But the ideal scenario.
Yeah, it's the ideal scenario almost. And then there is a struggle inherent to that. Because what we do see in academic literature is that refugee crisis, of course, brings about these mental health morbidities among those that were displaced, but quite comparably and also qualitatively looks quite the same in the host population.
Absolutely. So those were quite insightful, Srishti. And to the audience just joining in, we are speaking to the outstanding Srishti Sardana about increasing equitable access, mental health care access to refugee populations worldwide. Over to you, Marius.
Okay, thank you, Ashwin. Thank you, Srishti, for the insight. So basically, Western mental health therapies are often focused on individual health, versus mental health therapies in other countries may be more focused on collective healing. Since they have collective civilization, how do we waive cultural aspect when designing interventions and ensure that it is effective?
You know, I think of your question, Marius, and I can't help but think about sustainability.
Sure.
And let me tie that in. When we were talking about how, we've talked about vertical structures, horizontal structures, we've talked about tailoring interventions. So, Marius, if I had to just let myself think out loud about it, I would say, well, is it ever possible to go into a region? Doesn't matter whether you're coming from an individualistic or a collectivistic, whatever that means now, culture or context. Is it ever possible to go and tell an adult in another country, well, everything that you're doing is actually, nah.
Yeah.
Let me tell you how to do this.
Yeah, I see.
If somebody came to me and said, oh, Srishti, everything that you know, yeah, whatever, that's like your old knowledge from your own country. Like, this is not how you do it. Like, let us teach you. A fine example is students like me who come from developing countries to a developed country.
Right.
And we are getting educated in models of mental health intervention and evidence-based psychotherapies. And, then I go back and say, let me tell you how to do this.
Right.
No, that's really not the approach, because it wouldn't stay.
Right.
It doesn't stay. First of all, I think even if I force people to listen to me, I say force, because, I don't think that it has to necessarily, Western models of care have to necessarily superimpose over Eastern models of care. I also don't think that when it comes to mental health distress, when it comes to humanitarian emergencies, there is necessarily an East and West divide. Distress is distress.
Yeah.
It is universal. Trauma is an animal instinct that we were talking about. So, of course, there may be many differences. There might be linguistic, there might be race, there may be color, there may be socioeconomic, there may be educational differences, there may be political divides. It doesn't matter. When we go through tragedy and loss, we experience the same distress. despite our differences.
Yeah.
So it's true. It's true that in the United States, in my training, I have learned so far, and I'm training and learning as I speak, that it's true that the models of care look very different than in what we would ordinarily think of as a collectivistic culture. And a good example would be, when I was little and not doing so well in school, parents would speak to a cousin's parents, and cousins would get together and we'll study, and then the whole village will come together and say, what happened? Why is Srishti not doing so? Like everyone in the neighborhood, everyone in the extended family, everyone in the family, everybody would be interested. Will have something to say about it. But here it's not like that in the US, for example, right? It's an individual focused journey of experiencing a crisis and recovering from it. However, there are different resources that we work with. For example, like I was saying before, there is a helpline here. There's a phone call when you're distressed. We don't have that in much of the world. So those are some things to keep in mind too, that somewhere, in our work in Peru, for example, they were saying, one of the first things that the government wanted to do was to develop a hotline for people in distress, especially the refugees.
Yeah.
So I think there is merit in also thinking that one informs the other. Yeah. When one informs the other and works together, there is more retention. Retention of that skill, because people already are working with something that's familiar to them. And then it stays, it sustains.
Right.
Okay. Thank you so much for the insight. So right now, as you in follow-up about the sustainability, how quickly can we leverage training of members within the refugee communities to provide mental health first aid?
Very simple answer to one of the most difficult questions. Well, the simple answer is I don't know. You don't know.
Yeah.
And it's fine to not know. I mean, how quickly as we can keep people safe and alive.
Yeah.
Right?
Yeah.
Right.
Is it necessary that the moment a displacement has occurred, you show up with, finances and some resources and, drop food from the helicopter? Of course, we have to do those things.
Yeah.
Right? Because immediately people need resources to stay alive, to survive. But once those survival needs are met, that's when we start thinking about, all right, what are some of the longer term care needs of these people? We're thinking about women that are being displaced and get pregnant on the way. Women and girls experience atrocities.
Yeah.
During displacement. We read about it, we know about it, we research about it. Right? There are women who've escaped from war situations and active conflicts, and arrive on the other side and are about to have a baby. Right? So to think about what are the survival needs at that time. When we think about quickness, Marius, I think again I fall back on personal humility and immediately visible need of the person. I say, well, I am a mental health professional in training, which does not mean that I am the first person needed to provide mental health intervention in an emergency context. Yeah. If I happen to be in that context for some reason, and this emergency situation has occurred, I'm not going to sit there and do therapy. I'm going to probably go looking for water. I'm going to probably go look for a private space where a pregnant woman can give birth to her baby. You know what I'm saying? Yeah. So that's exactly where, sometimes we have to say, well, when we're leveraging systems of care, it's not so much whether you're one specialist, I'm another specialist, there's another specialist. It's a human emergency needing a human response. What can we do as people for people? So that's the quickest response that I would imagine we should be prioritizing. And then we say, all right, now people are safe. And now I'm a mental health professional in training. Is there scope for mental health intervention here? And then start designing and tailoring.
Sure. So again, for the audience who are just joining, we are talking with Srishti about increasing access to equitable mental health services for refugees worldwide. And this is the perfect time to ask your questions in the comments box to the side. And so let's continue, Srishti. So you have worked in the criminal justice system in India, and we often talk about victims in the mental health field, as also in this conversation. So let's talk about also the crime perpetrators. They seem to be victims too. So usually in some of these low and middle income countries in Africa or Latin America, we hear a lot of news that a gangster or a gang or a terrorist, they have a small operation in a clinic where they kill maybe dozens of people, and then the next day the entire village flees off from that particular region, and they end up becoming IDPs or refugees. So, do you think psychotherapists must be on diplomatic and law enforcement missions to provide and understand the needs of these crime perpetrators?
Ashwin, there is a part of me, in thinking about your questions, there's a part of me that feels angry just imagining those scenarios because I've seen it firsthand. So I can't help but feel that level of anger and disappointment in systems where systems have failed people.
Yeah.
Right. Systems that are inherently to protect people become systems of coercion and oppression and injustice. So I wanted to acknowledge that that's the feeling part of it. If I think about this question, well, I don't think that, first of all, a perpetrator and victim and survivor, right? A perpetrator is somebody who goes and does something bad to another person, sometimes to the effect that it can cost somebody's life.
Yeah.
A victim is someone who has just been affected by that bad incident and is so injured that they need attention, such as of a healthcare system or a protection agency or law enforcement. And then a survivor is somebody who was once in that victim stage, but has since been recovering, right? So now these are important categories when we are thinking about program development and implementation.
Sure.
Right? When we're thinking about funding, when we're thinking about targeting specialists like psychotherapists and assessing needs of categories of people. And if all of those decisions didn't have to be taken, then I would say, well, at the end of the day, everyone is a person. And everyone went through adversity. And one person got angry about it and caused adversity on another group. Another person didn't do that and stayed in their injury and pain. And another person decided to learn how to move ahead in life.
Yeah.
So that's one thing to keep in mind. The other is, I do think that an interdisciplinary perspective and an inter-sector engagement is required when handling very large societal problems, like social injustice, like refugee crisis. This is not a one-sector problem. It's a multidimensional problem requiring that type of interdisciplinary and intersectoral engagement. Of course I need my lawyers.
Yeah.
I need the police people. I need therapists. I need doctors.
Yeah.
I need engineers.
Sure.
Because I am looking at needs of food, shelter, clothing, integration to healthcare, integration to education, integration to employment,
Yeah.
getting on with life.
Yeah.
I'm thinking about civic rights. So I need anthropologists. I need other civic agents.
Right.
So I think that at the core of it is not like, oh, I have this specialty, I'm going to go ahead. No, especially in the criminal justice system, when we are really talking about a very serious matter, like somebody would have really killed somebody.
Yeah.
Somebody would have lost everything they had in
Yeah. Mm-hmm.
So we have to engage different sectors from different disciplines.
Yeah. And also, I believe not only in treating that kind of a criminal issue, but also from preventing it, there needs to be intersectoral engagement and government's investment into those programs, so that as you have worked with a lot of juvenile offenders, before they become either indoctrinated by bad influences or even religious influences that are that's so ingrained in them in the long term. We can try to prevent that even before that happens in this society.
They're children, Ashwin,
Yeah.
who needed a lot of protection and safety.
Yeah.
And upbringing that was with resources. In desperate times, when you carry a lot of hunger in your belly, you're really not thinking about morality at the time. And this is not about taking sides. Of course, this is a non-negotiable opinion to have. It's like,
Yeah.
you killed somebody. Of course, that's not the right thing to do. And there are repercussions.
Yeah.
And then to take a step back and say, well, you really had no food at home for days.
Mm-hmm.
You really needed to do that, like steal something to take it back home because you had 5 people waiting for you to get some aid back.
Yeah.
Right? So
Yeah.
I think that human desperation and adversity context has to be acknowledged. Anyway, yeah.
Right. Srishti, thanks so much. Thanks so much for highlighting the effect of multi-sectoral collaboration for better effect. So I want to know equally, in countries where substance abuse is part of the culture, depression and other mental health illnesses also seems to be indispensable consequences in society. You study social capital and social support network. What is research showing us about how social structures influence individual and mental states?
Stay tuned because that research is ongoing.
Okay.
And so we should have preliminary results by next year, and there would be some publications and we will know. But that's just the practical answer to that question. A little bit of food for thought response to that question is that I wouldn't say that there are cultures in which, substance use is a part of it. I think of substance use as, we have the opioid crisis here in the United States as we speak.
Yeah.
I wouldn't say that it's a part of the culture.
Yeah.
Right? But I would say that it is now definitely a part of the context.
Yeah.
I think of substance use and alcoholism as epidemics in a number of countries around the world. But due to stigma and taboo and the invisibility around substance use, we often don't talk about it. We don't speak about it. But in my limited kind of experience working with a clinical population in training that was recovering from chronic substance use, one thing became very clear, that, the pain and suffering that comes with living life through adversity, and we're specifically talking about people who have lost everything, right? The immigrants, the refugees, the asylum seekers, the IDPs, without any structures of care, without basic fundamental rights, they are now in a place where they don't even have a constitution that protects them or acknowledges who they are. Of course, there are limited to no ways of coping with that adversity. And if there is availability of substances that can help people alleviate that pain, that perspective makes sense to me. Because they may not have any other healthier, adaptive ways of coping with what they're up against. When you see so much violence, you want to numb the pain. Right? When you've just lost everything, you want to numb the grief that comes with it. Anything that helps to numb is where a person is instinctually drawn to go.
Yeah.
So it's true that, I think people who are chronically substance using, of course, when people are in recovery, they say things like, well, I lost everything.
Yeah.
Right.
Yeah.
And so that's when all the work begins. Like for a mental health professional, that's where the work begins, where you're saying, well, all right, we're going to regain parts of your life. There are tools that can help you get better.
Yeah.
It doesn't have to involve drinking to death. Doesn't have to. It's going to be tough, but you're not alone anymore. I'm with you.
Yeah.
So.
Oh, thanks so much, Srishti, for the insight. And it's evident that the sport is highly required to bring these populations back to life. So our next question is to know what experiences propel your interest in studying clinical psychology and mental health.
I always joke with my parents and say, well, you guys inspired me. What were you doing? I was so confused. That's a joke. Yeah. I think there was a lot of in family and the heritage, there was a lot of focus on education for girls. And believe me when I say this, Marius, that is not a given in the country I was growing up in. So, in the context in which educational rights, access to becoming a professional, becoming financially independent, finding a place of our own. I have a younger sister, and there was a lot of focus in generations worth of my family, where a lot of the focus was on women getting educated. Whether we had a lot of money or not was not the priority. The priority was that, you get educated in the service of social benefit. Yeah. Now, obviously, when one grows up, and when I talk to friends and colleagues from other countries now who are also growing up within the context of low resources, their experiences are not very different from my experiences when I was growing up as a young girl, which are like you're kind of up against very, very limited resources that can be put aside for your education, that can be put aside for your recreation, that can be put aside for your development. And, that type of, when you witness adversity and you see that, your family is really trying their best to make sure that there is no deprivation, and you're kind of in between, I see deprivation next door or in front of me, and I have these few privileges, and this is everything that I have to utilize, to grow. That level of exposure really shapes a person.
Thank you.
Right? And I think that might have shaped some of my earlier thinking that, physical resources, you may increase physical resources in a person's life, doesn't necessarily bring a sense of well-being. Right? And then when people are doing well, doesn't necessarily mean that they become functional enough to go and get more resources for themselves. So it goes hand in hand. The physical and the mental health go hand in hand. And I just chose to be, and there were enough doctors in the country I was growing up in. So I decided to go where there was fewer of us. So therefore mental health became quite a choice then.
Gotcha. We do. Thank you, Srishti. We do have 2 audience questions here so far. And the first one is, how can family members identify and address preliminary stage mental health issues?
Yeah, thanks, Indira, for that question. I think one way would be to, especially I'm thinking about families in social contexts where stigma is very high. So, and then there is that part of, can somebody really have mental health issues in my family?
Yes.
It's a very personal question also, right? So to give an academic response almost feels incomplete to me. So I'll give a personal response to that. When one notices that, somebody in the family was doing what they're supposed to be doing in a given day, they stop doing those things or start to underperform in those roles.
Right.
That is one of the first indicators that the person is not doing so well.
Right.
So an example would be, if I was used to seeing that, my husband, wife wakes up in the morning and is able to pack lunch for everybody, is able to get children ready to go to school, then goes to work, comes back from work, is able to cook a meal, sit down at the dinner table, have conversation with the family, and then, go to bed. And then suddenly I start to notice that the person has a lot of difficulty getting up in the morning, getting out of bed. They actually forgot to pack the lunches. What happened? They didn't go to work today.
Sure.
They stayed in bed all day.
Yeah.
And when we all sat down to have the meal in the night, they were so quiet. We had to actually force them to come and sit with us and have a meal.
Right.
And then they had so much difficulty falling asleep. They were up till 4 in the morning, not really doing much. So you see, like, this person was functioning in roles that they were supposed to function in. And then you start seeing that they are drifting away from that is a pretty good indication. And the family really sees it.
Yeah, at least the initial.
Yeah, it's just that part of like indication of, whatever was your baseline, you're drifting away from that. What is going on? That sometimes is an indication of distress.
We also have one more question, 2 more questions actually. So one from KJD. Are there developments that are poised to have significant impact on equitable access to mental health care? How are new technologies impacting access to care?
Yeah, excellent question. I am not the expert on digital health and telehealth, but I do know some of my colleagues and actually advisors and teachers who are experts in this scope of work. And KGD, I think there is a lot of focus on digital advancement and use of existing technological infrastructure in much of the world to meet the ever-increasing needs, especially for mental health. Some examples that come to mind are, the Veterans Affairs in the United States has pioneered telephone-based therapy for many, many years. And one of the reasons for that was that a number of veterans live in rural pockets of the country that don't directly have access to a hospital where they live.
Yeah.
Or so far away they can't reach it, but they do have a phone.
Okay.
Similarly, this was a joke, it's now a reality, and we know that in countries like India and Pakistan, most of the country carries a mobile phone.
Yeah.
Even to the extent that some countries actually provide free internet, or internet is just cheaper on the phone than actually having a landline connection now.
Yeah.
So this is absolutely spot on in terms of a question that we are beginning to leverage some
Right.
of these existing infrastructural resources that many countries around the world have. And we're seeing that in some of the work that my lab does, where that there is a lot of flexibility in how interventions are provided. Dr. Verdelli would always say, well, what is the routine care? And if in your routine care, there's a patient who's, able to get therapeutic support via a phone, or
Right.
actually be on the internet and do a Zoom or Teams or whatever,
Yeah.
let's do that. Let's meet them where they are.
Right.
Yeah.
Right. And a related question: if one becomes, if one wants to become more knowledgeable on mental health access for refugees and closely related subjects outside of academic journals, are there books you recommend reading?
Oh, yes, actually. It's a good question. One of my favorites is, and let me be sure that I am not telling you the wrong name. This is Borderlands by actually Dr. Peter Ventervogel, who I mentioned from the United Nations High Commissioner for Refugees. And it was his 10 years worth of, he's a medical anthropologist and a psychiatrist,
Okay.
and has been, thanks to my advisor and the lab, was actually able to, learn and have an opportunity to work with him. And it's called Borderlands of Mental Health.
Okay.
And it is explorations in medical anthropology, psychiatric epidemiology, and health systems research in Afghanistan and Burundi. It's a terrific, terrific book. And really written in a very approachable way. It's talking about many areas that the globe today faces in terms of continuous armed conflict, and the psychological and social effects of that.
Right.
The other one that comes to mind is actually Pathologies of Power by Dr. Paul Farmer.
Okay.
Which is a terrific book because it does talk about understanding of this other aspect that we've talked about of, civic and human rights in the context of illness and disease and death. That's another one that comes to mind. And then the one that he just wrote, which is Fevers, let me tell you the name, Fevers, Feuds, and Diamonds. It's about Ebola and the ravages of history. That's another nice, interesting, powerful book to keep in mind.
Dr. Paul Farmer is such a role model in global health.
Yeah.
Along the lines of education, Srishti, there is a dearth when it comes to human resources for clinical psychology and mental health. Mm-hmm. And there seems to still be a prevalence in terms of the clinical psychology or mental health field, where there is low awareness, parents not encouraging students to embrace psychology or take up psychology as a profession. Do you think that this is due to lack of awareness, or are there things we can do at the grassroots or governance levels to increase clinical psychology and mental health? Psychologists in general?
Yes, definitely we have to increase the capacity and presence of mental health specialists. There aren't enough. Imagine you increase awareness in a family that, okay, your child actually has a developmental disability.
Yeah.
And then they're like, oh, okay, what are the indications? And you give them whole indication checklist, and then what do I do? And I say, I'm sorry, there is nobody in this country that can help you. Yeah. Or the person that can help you is 2,000 miles away from you and will charge you this much money and will be able to see your child, right? So there is that part of it also, that you can identify that there is a mental health problem. But then if you don't have a system of care that helps this person, then that's not really useful.
Right.
So I think some of the work that Dr. Verdelli and Dr. Vikram Patel and others have done over the years is the involvement of, and Dr. Atif Rahman in Pakistan, the work that they have done is around involvement of laypersons
Sure.
and non-specialists. So, in Pakistan, there is a lot of research around lady health workers and the involvement of women in the communities. This is not about people getting degrees. You don't have to have an MS or a PhD in clinical psychology to provide mental health support and intervention. A lot of the work can be done with good training and capacity building at the level of the grassroots with lay people, with non-specialists.
Yeah.
Which is, by the way, not to say everybody can be a counselor or a therapist, not at all. I think this is a very serious problem, right? So we have to take it seriously in terms of training and supervision and making sure that capacity is created in the grassroots in a very systematic way. You teach people skills, you adapt it to the local culture and context, you see it through, provide guidance on how to provide intervention.
Right.
And then phase out.
Yeah.
So.
Well, I just want to thank you so much, Srishti. This brings us to the end of our discussion, and this has been, quite a wide-ranging discussion and such a gripping conversation. And we all knew that this is such a serious subject, but you did add to how important this subject is and requires national and grassroots level awareness, implementation, and increased focus. So thank you so much for your time, and we look forward to having you once again.
Thank you. It was an honor for me. Thank you.
Thank you. And also we thank our audience. We appreciate your questions and looking forward to seeing you next week. Bye-bye.